Welcome back to part 2 of our special edition of the Prime Project applicants research and progress rounds. It's my pleasure now to introduce Dr. Amy Nakajima. She completed her residency training at the University of Saskatchewan and received her Royal College certification in obstetrics and gynecology in 2000. She provides care at the Wabanel Centre for Aboriginal Health and at Bruyère Continuing Care, including the St. Vincent Hospital site. Dr. Nakajima is an active clinician teacher, providing both didactic and simulation-based teaching at both the undergrad and postgraduate levels. And she also contributes to patient safety and quality improvement teaching, having developed elective experiences for medical students and workshops for residents at the University of Ottawa and faculty development sessions. And today she's going to be talking about one such workshop for residents. She's contributed to the development of national patient safety resources, including the Canadian Medical Protective Association's online patient safety curriculum for medical students and faculty. It's called the Good Practices Guide. She's an advisory member on the Royal College of Physicians and Surgeons Canada's CanMed 2015 Patient Safety and Quality Improvement Expert Working Group, and is lead author on the Royal College Competence by Design White Paper on Patient Safety. It's called Just Culture of Patient Safety. So Amy, thank you.
Thank you so much, Doug. So it's my privilege today to present on behalf of Dr. Weiner and myself a pilot project to test feasibility and acceptability of a simulation scenario to assess the ability of family medicine residents to manage obstetrical emergencies. And I did want to thank everyone in the room and not in the room who has contributed very generously of your time, their expertise, their wisdom, including Dr. Weiner, Dr. Archibald, and I wanted to thank Tanya too for her expert putting together the grant writing series and the current manuscript writing series, and thank you, Dr. Delva, for promoting those initiatives because they've been tremendously helpful.
And of course, Dr. Liddy, who's leading those.
Yes. And if there is anyone that I haven't mentioned, including Dr. Campbell, who's sitting right behind Doug. So this project really started out with a really interesting conversation at a number of tables, because there's a tension between our educational expectations and our clinical and educational realities. So when we ask the residents, family medicine residents, how do you feel about your competency in performing vaginal deliveries? Well, less than 2/3 feel competent. And when we look at our family medicine teachers who are providing teaching in obstetrics, there's 10.1% of them, and their numbers continue to decrease. So there is a tension, and that tension can be explained by a certain number of factors, such as inconsistent or possibly lack of clinical exposure. And when we look at clinical volume, the number of deliveries that they have divided by number of learners, you may have a dilution of that volume so that the learner themselves are seeing not a lot of deliveries and having that ability to be participating in those deliveries and management of obstetrical emergencies. And then possibly the inconsistent or lack of educational experiences in maternity care. So patient safety becomes an issue. So the teacher feels obliged to step in because of that concern to patient care and not being able to allow their learners to actively participate and manage an obstetrical emergency. It is a higher risk clinical environment from a medical legal perspective. And there are decreasing numbers of family medicine accoucheur role models and teachers. So that leads this discussion into simulation. So for instance, we're using simulation to teach CPR instead of in these incidental moments by creating educational opportunities to learn how to do chest compressions to manage cardiac emergencies. So why simulation? And what is simulation? It is a technique to replace or amplify real experiences with guided experiences, often immersive in nature, that evoke or replicate substantial aspects of the real world in a fully interactive fashion. And by immersive, we mean that the participants who are there feel like they are in a real environment, as if this moment was happening in the real world. And simulation modalities have certain advantages. We can design and deliver standardized experiences to students. We can observe them directly. We can videotape those experiences, and those videotapes are very, very often helpful in the feedback session so that participants can actually see what it was that they were doing and saying in that simulated environment. So it gives us an opportunity as teachers and educators to assess and provide feedback. We can manage to give them personalized assessment of their learning gaps and to address those learning gaps. From a learner perspective, they are highly engaged using simulation. And it also enables the teachers and the educators to provide sensitive exams, such as the gynepelvic exams, things that we might not feel comfortable doing with the patient, especially as they're just starting to learn. And it also allows us to provide clinical scenarios of high-risk, low-frequency events. And by that I mean the rare life-threatening event. So we can't, unfortunately or fortunately, as teachers, we can't schedule these events. They happen, and the teaching around them is incidental. And from a obstetrics perspective, the teaching can become awkward, counterproductive, because the patient is awake. There's a high degree of expectations around what is happening, and very often there is a partner, there's a family involved, so teaching in this environment becomes very, very challenging. And that simulation allows learners to be exposed safely in a standardized manner, and allows them to make mistakes. And when we look at simulation, it is a broad category. It's an umbrella of a variety of teaching and assessment modalities. And very often we forget about role play, case-based learning, but those modalities enable us to really give the learner an immersive experience. They are in an alternate environment when they're in that teaching moment, if we're successful at engaging them. And we move next to standardized patient, also to part task, hybrid, which I will be coming back to later to explain this proposal, video-based and a high-fidelity mannequin. And as you can see, I've kind of arranged them from technologically very simple on your left to the very complex to your right. And price point also moves from your left to your right. But the question is, where is fidelity? Because fidelity doesn't often correlate unless your teaching is thoughtfully integrated. So we'll be coming back to that thought as well. So as you can see, instead of using just a recess Annie, you have a more sophisticated mannequin in this instance. You can see that it's more immersive. They have more equipment in the background. But this is also a challenge for the teacher to be able to thoughtfully and creatively and integrate this into a learning situation and to do it in an authentic manner so that it feels real to the learner. And just to go over what a simulator is, it's a physical object or representation of full or part tasks to be replicated by the learner. And it usually refers to a device that presents a simulated patient or part of a patient and interacts appropriately with the actions taken by the simulation participant. So it needs to respond in a real way. And there's nothing new under the sun. So this is a obstetrical simulator from the 1500s that were used by midwives. Yeah, and as you can see, there's a picture of a baby, obstetrical mannequin. You see the fetus with even the umbilical cord attached. So these are part task trainers. It's a device that replicates limited aspects of a task, but does not present an integrated experience. And it's a simulator that includes only essential parts of the task, and non-essential elements are excluded for portability and for cost sakes. For instance, very well suited for basic procedural skills. such as catheter insertion, suturing, and so forth. So this is an example of a birthing pelvis, and as you can see, it is really pared down. It's a pelvis, there's a baby. You can see on your right an example of a delivery. And coming back to that hybrid simulation, this is a combination of a standardized patient plus that part task trainer, which you just saw on the previous slide. And that refers to a hybrid simulator. And the advantage of a hybrid simulation is that you include the patient interaction. So it's not just the physical or technical task or procedural task that you're asking your learner to undertake. It also includes the challenge, that extra added challenge of the communication piece. And so the hybrid is a combination really of your standardized patient plus a part task trainer. And here is an example of your standardized patient in a bed and your learner doing a delivery. You can't see the birthing pelvis, but it's put in between her legs. So now that the learner needs to also communicate with the patient. And that's one of the advantages of using hybrid simulation. The learner is able to better buy into the scenario. It's more complex. The scenario looks more real, more relevant, more authentic to the learner. And it also includes the difficulties of integrating skills from different domains. So the clinical domain with the task or procedure plus the communication piece. And the advantage of simulation is that we move up Miller's pyramid. So from a pedagogic perspective, instead of using our written exam, our multiple choice exams at the nose level, we're moving up 2 levels to show us how. And in fact, simulation has moved up the ladder 1 more to does. So this is an example of a retrospective study that was done by Draycott and his group in England, looking at a single center in the UK. And what they did was their intervention was shoulder dystocia training, which is indicated by ST training. And when they compared before and afterwards, there was an improvement of clinical management. But the holy grail of simulation is what happens to your patients. The patient outcomes actually improved. So the rate of brachial plexus injury, which is injury to the baby due to a shoulder dystocia, which is not well managed, actually had decreased from 9.3 to 2.3%. And these are large, significant numbers. And so the objectives of our pilot is to test the feasibility and acceptability of using an obstetrical simulation scenario to formatively assess the interpartum skills of U of O family medicine residents from the perspectives of both the learner and the faculty, and to test the feasibility of a novel scheduling of the scenarios, and to enable participating family medicine residents to receive multi-source feedback through direct observation, and then to be coached thereafter. And the theoretical framework for this model is based on Erickson's work. And so he looked at what is currently happening, the current experience, which would be the simulation, in reference to a past experience and to future action. So starting with the simulation, which would be the performance, it is being assessed by your faculty member, and the FM resident is then given tailored feedback, and then through that tailored feedback is allowed to be coached to improve performance. So this is the improvement through direct and deliberate practice. And that process looks at reflecting in that action, but it also looks at reflecting on previous actions. So how did I improve on my last case? Last case I did what? How did I improve this time? And that feeds forward to how you are going to manage in the future. So our pilot is a small one. We're aiming for an NF15, family medicine, both PGY1 and PGY2 anglophone. And we are for our faculty, we're hoping to recruit faculty at the TOH sites that deliver, so that would be at the Civic, and the General as well. And our novel proposed scheduling solution, because this has been a challenge, it is one of the identified challenges to simulation, testing, training, and assessment, is how to get everybody there. So we're piggybacking onto the MNCC meetings, which are the monthly meetings for the TUH staff that perform obstetrics. And we're using mobile sim by going into their site, not asking faculty and students to go to some other place. And this is an overview of the project. So prior to the sim, we'd be asking both the residents and the staff to fill out a demographic survey. And then at the time of the simulation, the residents will be providing feedback on their experience, what they learned, what did they value from this experience. And then from the FM faculty will be asking for their resident assessment of the performance. And then moving forwards, post-simulation, 3 to 6 months, we're asking for a reflection piece from the residents to be completed. And then for the faculty, we're asking for a focus group. And the simulation scenario has been created, and we've based it on a document that was just released, looking at competence in intrapartum and perinatal care and family medicine. We're also including a global rating of performance and an assessment of entrustability. And so our analysis would be looking at data collected from the demographic surveys, resident feedback, and also looking at resident performance, which will be assessed by a rubric, global rating, and an assessment of entrustability. And the resident reflections and faculty focus group, we will be undertaking a framework analysis to complete our qualitative analysis. And acceptability will be looking at that from the feedback scores, and feasibility will be looked at by rates of faculty and resident recruitment, and the number of scheduled sessions, and if we have to cancel sessions due to difficulty for recruitment and scheduling purposes. And so in terms of our timeline, we've created all of our documents and items. Next step, Gary and I are waiting to present at the next MNCC meeting at the end of May. Hopefully we will start recruiting faculty at that point and asking for their feedback on documents and items, and hoping to submit to RUB later in the summer. So thank you very much.
So great presentation. Thank you. It's very clear for someone who's not a physician to understand this. So thank you. But I had a question in terms of when you're using the rationale that there's declining sort of obstetric care given by family physicians. Do you feel that that's really attributed to the lack of the training environment or times to have that experience? Or from my understanding, there's a lot of other situations going on in terms of timing of deliveries, and so I'm just wondering whether that's like the true rationale. And then I'm wondering if that is in terms of opportunity, to what extent are there barriers? Can you explain what the issue is in terms of interprofessional collaborations and working with midwives and obstetricians? So do family physician residents only have to work with family physicians to get the obstetrics training, or how does that work?
I'm going to ask my co-presenter, Dr. Varner, to take that question.
That's a whole bunch of really interesting questions. We know there's declining in whether that's because of the tensions, whether it's because in Ontario we've set up a non-collaborative environment around obstetrics, which is actually a competitive one, so that our residents, our family physicians who do obstetrics are competing with midwives and obstetricians who do low-risk deliveries. Are all factors in all of this. But we also believe that exposing residents to a positive environment where they're feeling less threatened by feeling not skilled enough to handle an obstetrical emergency, which is a requirement of our program and a requirement of the College of Family Physicians. They have one of the Red Book requirements for, which is the accreditation document for family medicine, is that residents graduate with skill in providing care in obstetrical emergencies, and yet we never can really realistically give them that opportunity. Is a major problem. And so if you give them a positive environment, and that's not only created by the physicians, of course, there's the labor room environment, which is challenging at the best of times. But you give them the experience that's positive, give them the mentorship, and give them the training that they would need to handle the emergency, may actually make it easier. But yes, there's many other mitigating factors. Does that summarize it?
So what about the interprofessional component? Any thoughts on that?
We don't, in Ontario. If you're in BC, I know Vanessa could comment much better on that because she was there. But in Ontario, as a family doc, I never, unless it's accidental, see midlife. And we would never be working together. Ontario has created this environment where we can't collaborate. And obstetrically, of course, we're collaborating all the time because they're our basis for security, working in a busy case room like a teaching center. And of course, we're always working with nursing.
So I'm currently one of the providers who do the emergency training for residents right now. We do basically a boot camp in the summer. Have you considered using us as a control and just measuring whether your simulation, I mean, it'd be sort of an easy thing to add on, but using sort of what we do already. I mean, we do sort of we do a bit of SIM, but yeah.
So Vanessa, thank you very much for your question, because that's actually the nidus of this project.
Okay.
Because we looked at that.
Uh-huh.
And Dr. Wolterton kindly, in fact, offered the opportunity to organize something a bit more formal. And it was really challenging to have residents released from clinical duties, other competing educational experiences, and to get staff involved. So it became very challenging for me, who's not a family physician, to try to, I think, really understand how many learners your department has, multiplicity of different scheduling. Dr. Viner had to explain it to me at least 3 or 4 times, and I'm still not clear. So I think from a variety of inputs, Vanessa, we felt that starting with a really small pilot would help us see if it was feasible before we started thinking about sizing up.
But that would be the obvious next step. Right?
Yeah.
Yes.
Yeah.
This is the feasibility stuff.
Yeah. Dr.
I had a question.
Yes.
You talked about the resident feedback.
Yes.
I'm just wondering, in the simulation part, is there
Yes.
an opportunity for them to self-assess following the simulation as part of the reflection on action piece that you've done, that you showed in the diagram?
Yes, there would be an opportunity to do so, and that would be in that feedback or debriefing stage.
Okay.
So during that personalized debriefing from the family medicine faculty, that would be part of it. So that debriefing phase should include the invitation from the faculty to ask or prompt the resident, so how do you think you did? How did that go for you? How did that feel? And so unpacking that, I think, will really help. And that's why radar training is going to be important.
Okay, just
Yes.
along with the self-assessment piece, whether or not you would have a rubric so that everybody is self-assessing on the same knowledge and skills and experience, whether that might be a thought.
Thank you for that comment, because I think Gary and I will sit down and talk about that later on. My initial thoughts would be to have that, as it's videotaped, as we're viewing that, we can try to extract some of the themes that are moving forwards, but we hadn't thought about formalizing the self-assessment piece in that way, but thank you.
Yeah, Gary has a lot of experience in teaching and education research, so
But just things that come to mind. I know how
Yeah,
critical that debriefing part is, right? For the learning, it's such a critical class.
So if you're staying later.
To just, share ideas. Thank you.
I think Doug, you had a
Oh,
question.
mine was just strictly logistical. I noticed that you suggested putting your REB in for June, July. Now, if you want to start in September, really, you gotta get that.
I saw that too. June, July, starting July.
Yeah,
That ain't gonna happen.
Yeah, that's just
Takes
a
a long
logistical thing we can talk later, but you gotta get that in.
Yeah, that's okay, everything else.
We had to push this timeline a little bit forward.
Yeah, that's it.
But that's okay, we always do that in our research. Nothing happens in the timeline, so don't worry if that happens to you, I'm in another
I'm
road.
glad, Simone, that you are not remembering what the original timeline was.
But very clear presentation.
Yeah, wonderful.
Any other questions?
Okay, that's great.
Thank you very much.
So we're right on time for
And our last presenter is Dr. Vanessa Murley. She's an assistant professor with the Department of Family Medicine. She's a staff physician at the Ottawa Hospital Academic Family Health Team and maintains active privileges at the Ottawa Hospital Civic site, the Department of Family Medicine, Division of Newborn and Maternity Care. So, on to you, Vanessa.
Thank you. Oh, sorry.
Oh, sorry.
And this is great. So I actually just got involved with this study in the last couple of months, so I have to thank Doug Archibald for that. So basically what I'm going to be talking about today is it's a pilot study just testing a novel approach to cessation in primary care settings. So for the clinicians in the room, I guess, you know, all of us have been trained in the Ottawa model of smoking cessation. What do you think is the biggest barrier to getting your patients to quit smoking? Anyone? No?
Rings.
They don't want to.
Exactly, yeah, exactly, they don't want to, right? So this is the research team. I'm working with Dr. Andrew Pipe, who is, of course, I guess probably Canada's #1 top researcher in smoking cessation. Robert Reed is also involved, so he's the Deputy Chief of the Research Centre at the Ottawa Hospital Heart Institute. And also Sophia Papadakis, who has, she's written lots of papers on smoking cessation. And then Mustafa Koja, he's the manager of the primary arm of the Ottawa model for smoking cessation. So basically it's a pilot study to test the feasibility of whether a novel intervention for smokers who are not, to test the feasibility of a novel intervention for smokers who are not ready to quit. So basically, traditional smoking models, and the one that we use right now in the protocol for the Ottawa model, is basically only focuses on patients that are willing to quit in the next 30 days, right? But we know that in primary care, 60 to 65% of patients are not interested in quitting, okay? You know, there's a large Cochrane review that has showed that in the not ready to quit populations, if you offer them smoking reduction instead of cessation, they're actually more likely to be abstinent at 1 year if only offered smoking cessation, okay? And that basically new approaches are required to reach the not ready to quit population. So we know that also the NRT, it can actually increase your success rate in quitting when it's used as a reduction strategy, okay? And that varenicline has been shown to reduce tobacco use among patients not willing to quit compared to controls. And so you know, I think it's important to, you know, right now we're using this current guideline. However, other countries like UK, the NICE guidelines recommend that smokers that are not ready to quit consider NRT to help promote smoking cessation. And certainly, I don't know if you can all imagine your patients that are, you know, the sort of hard smokers that have been smoking for years that wouldn't consider smoking, consider stop smoking using a harm reduction approach can help perhaps their morbidity, mortality rate. And especially if you think about mental health populations, right? So schizophrenia, things like that. So the Ottawa model for smoking cessation, so it's based on the 5 A's, which I'm assuming everybody's familiar with. And it's the assess A, right? Whether you're ready to quit or not is sort of where the protocol takes a different turn. It's partnered with over 80 primary care organizations across Ontario. So there's a large platform that if the study does prove to be feasible, that it could be spread abroad. And then, of course, there's over 900 healthcare providers. So basically, the primary objective is to look at whether this is a feasible. So basically, can we recruit practitioners? Are they willing to engage in the study? And what their completion rate of not ready to quit assessments would be. Okay. The secondary objectives to see if the intervention will increase the number of smoking reduction interventions, whether it'll increase provider confidence, and whether it'll increase provider satisfaction. So this is the flow. I don't know if you can actually read it from there. Maybe not. I'm shaking her head. So because it's a small, it's a pilot study, so looking at whether this is a feasible intervention or not, we'll be recruiting 10 primary care clinics only within the OMSC. So we'll be looking at practices only that have more than 5 healthcare providers. Basically, we'll collect baseline data, so demographics, and what their current practice is. So what is their current practice for patients that are not ready to quit? And then basically what their confidence is in addressing patients that are not ready to quit. The clinics will be randomized, so each clinic itself will be randomized to either the intervention or the control. So healthcare providers within the same clinic will be part of the same randomization. Does that make sense? So it'll be 5 and 5. So the control group, they will still complete a survey. So every time they see a patient who is not ready to quit, they will complete the same survey that will occur in the intervention group, where they will say what they did essentially with that patient that was not ready to quit. Whether they did nothing, whether they provided self-help resources, whether they referred them for counseling, or whether they did offer them NRT or medication. And then there'll be a 3-month post-assessment where we'll look at those forms, so basically how many not ready to quit assessments were completed. We'll look at confidence in both groups, and then we'll look at satisfaction. So essentially the intervention for the intervention group is basically like a lunch and learn, or an evening. I don't know, I'm sure everybody's done the evenings with Dr. Pipe. Yeah? Yep. All right. So this is the current protocol. So you ask, do they smoke or not? And often the nurses do that. It's been touted as sort of the 4th vital sign. Then we advise them to smoke, and then we assess if they're actually interested in smoking in the next 30 days. If they're not ready, what we've done usually is just provide self-help material. So there's a booklet that we're provided. So the new intervention is that if the patient is not ready, we'll either ask them if they're interested or not in learning about how we can maybe help them. Okay. So if they're interested, either at that appointment, we can sort of offer them intervention, or they can be referred to a smoking cessation counselor who will then offer the same intervention, which is sort of what we're doing. It's what we're doing right now at our current family health team. Yeah. So the analysis will be done by an investigator who's blinded to group assignment. The consults will be compared with a t-test. And I guess we'll incorporate a variance inflation factor. I probably shouldn't have put the slide on, because if you want me to explain that, I won't be able to. Although I do have some familiarity with t-tests in my last world as a plant biochemist, but that was a very long time ago. And then summary statistics will be provided for the satisfaction with the intervention and the smoking reduction group. So, and then the dissemination. So of course, ideally, we'd be looking for a publication. We'd also perhaps present the intervention at Family Medicine Forum. And then if it proves successful, the Ottawa Model for Smoking Cessation Primary Care Network would be used as a vehicle to sort of launch a broader study. So that's that. And then, yeah, so any feedback? Any questions?
Can you get the slide back for what the intervention is? Just, so if you're not ready to quit, there we go, okay?
But the intervention is on the other one, right?
Yeah, so
So if they say they're not ready, they assess and they're not ready, so it's the,
so it's
a reduction, yeah.
So I mean, I've certainly never met a smoker, I have met a smoker who's not really interested in quitting, but I mean, everybody knows that it's detrimental to the health, right? I mean, you're not going to find, I think everybody knows that at this point. So if you sort of say, well, you don't have to quit, but maybe we can help you.
I guess what I was wondering is, so cellular assessments are related to the provider, so the practice folks, but would you actually see whether anybody actually accesses the Yeah, the harm reduction, and I'm not sure sort of, what did they get referred to? Is there like a group session or, so
No,
there's two
so-
little boxes
Yeah.
to the bottom, yeah.
So the intervention is either going to be behavioral modification. So you tell the patient to either stop smoking in their car or stop smoking in their house.
I see.
The other options are, of course, varenicline or NRT. So those are the sort of the three options that would be provided. With, of course,
the middle one, sorry?
varenicline.
Oh, yeah, okay.
Yeah, so Champix.
Yeah, okay.
So in the context of this morning's announcement, the British Medical Association has recommended the e-cigarette.
Oh, yes.
The question is, how are you going to be able to look at this with changing social
Right.
pressures and
Yeah.
environment? Can you see any way that you're going to be able to adjust for that?
That is a very good question, and I would have to bring that, back to the research team. I mean, it certainly could be incorporated into the behavioral modification group. I mean, e-cigarettes are, essentially another type of NRT, right?
Yes, exactly.
Really. So, yeah.
But it just suggests that the social context has changed.
Yes, it is, yeah.
And
And so the model has to adapt and be flexible.
I'm interested, go ahead. Oh, yeah, so I was just, I guess what I was just wondering about, nice overview, and you gave a good presentation. And I guess what I'm wondering about is the intervention that you're measuring though, you're going to measure at the provider level? So are the providers going to attend the workshop, and then are they actually going to do this new pathway?
Yes.
And not so much,
We're not going to be looking at smoking cessation rates
In terms- that's right, yeah.
Yeah, because it's the sample size is obviously.
Yeah.
But the idea is to, basically to streamline the intervention so that it can be used in a larger setting, right? To make sure that it's, it actually works to increase their confidence.
Right, yeah.
But you are, so I mean, not
Yeah.
the smoking cessation rate, but you are going to measure whether, how many patients were not ready and whether they were, if they agreed to have harm reduction, because I think
Exactly.
it is.
Yes. So that is part of the survey.
Mhm.
So that is part of the provider survey. So what was the outcome? So it was about
Is it
5
provider
patients.
survey, so you're not measuring it at the individual level, it's the.
No,
Hmm.
at the healthcare professional. So
Yeah, that's
the-
good. Yeah, you
Yeah.
might want to consider that the bias, self-reported bias, as
Right.
opposed to asking them to track the
yeah,
patients they
that's
approach.
right, yeah.
So if you ask them, so how many patients did you assess for smoking?
Right.
Were ready, fine, were not ready, but agreed, yes, interested, no, not interested, even if you got there. But if you ask them to track it as opposed to have self-report.
Oh,
As opposed to asking the doctor,
right.
did you do it, and did you have some patients who agreed, and
Yeah.
because it's well, first it's difficult to recall.
Well, they'll do it at the time of the appointment.
Right, but in your measurement, your outcome measure,
Yeah.
how are you going to determine whether patients actually agreed to do the harm reduction?
Yeah, it'll be the healthcare professionals.
So he's going to say, yes, some of my patients did, and that's what
Yeah.
I'm wondering,
Yeah, so what it is that, yeah. No, I see what
whether
you're
they
saying.
should be capturing it for each encounter.
Okay.
So there's some, as you know, publication bias about
Right.
studies that don't work. I might put you in touch with Jerry Borowski at Dalhousie.
Okay.
He did a study with Champax, made it available at the desk or something to people that didn't want to quit. And they abandoned the study because it didn't help. So I think it would be helpful to know that your intervention, if there is evidence to show that using Champax in people not ready to quit is actually helpful. And maybe get in touch with Jerry, because I know he was doing it as a pharmaceutical sponsored study,
Okay.
and that probably didn't get published.
Yeah. So this, patients will be treated for up to 24 weeks if they chose that treatment. There is, there are studies that show that it is effective at reducing smoking and increasing.
I think capturing it here is beyond the scope of this.
Yeah.
This study rests on the assumption that it will, but I guess you at least want to know that they're going to go down that path. That, that's,
What sort of numbers are you anticipating? Will you have the power to be able to detect difference?
So, in terms of recruitment,
In terms of number of patients that
Yeah.
are coming in,
Yeah.
every
So,
site and over the period of time?
yeah, so that's the thing, it's a pilot study to see if it would be feasible to recruit and whether we can basically, it's really more on the provider level, can we increase their confidence and increase, I guess, their attempts to counsel patients who aren't ready to quit. So because of that, because it is a small study and
So so what would be the purpose of the randomization? Perhaps it is to see whether folks would be willing to get randomized to do nothing. But
probably because, different clinics operate differently, right? So I think a lot of the Ottawa model has to do with who your champion is. And so, really, you could probably say that some clinics are overperforming and other clinics might be underperforming. So the randomization would hopefully exclude that bias.
But your outcomes are around the feasibility and acceptability. I guess maybe I didn't see I'm not understanding the outcomes well enough.
Okay.
So if it's feasibility and acceptability, the control's not going to contribute anything. If you were looking at outcome in terms of smoking cessation or patient's engagement or something, then it would make sense to have a control. But if you're looking at strictly at whether the physicians were willing to participate, whether they were happy with the protocol that was given, the training, whether they felt they were able to help the patients, I'm not sure what the control arm is going to give you. So I don't know, maybe somebody else can contribute, because I see the value of having the control here, which is probably not sufficient enough to have it, would be to say whether a practice would be willing to participate as a control given, in this type of thing. But what do people think?
I think you're setting it up for the RCT, right?
Yeah.
That would be my,
Yeah.
Did you do the design, or was sort of a team that did the?
It's the team that did
Yes,
the
so
design,
that's, my view is this is that's right.
Yeah.
So then the study is the design for the RCT.
Yeah.
And so you're answering exactly that question,
Exactly.
whether or not the recruitment.
It's a super interesting question though, there must be literature on that. Not that you have to look for it, but there must be, right? Someone must have said, if you want to do an RCT, you should do an RCT.
Well, I would say that's usually, it would be a two-step.
Yeah.
So it would be, the feasibility and acceptability only in your intervention group.
Yeah.
And then you'd talk, if I was to roll it out, what would it look like? And then you'd have your smaller RCT, right? So it looks like we're trying to do two things at the same
Maybe
time.
they feel they've already done their feasibility overall because of the background, because of how much is established.
But their outcome is strictly related to feasibility.
Yeah.
So that's, in terms of acceptability, so. Or we can look at the outcomes together, and this is Andrew Pipe, so he knows what he's doing, right? But my point is more, is this the most efficient? And why are we stopping at 10 practice is because of the budget. Just because of budget limitations. So it's not that he thinks this is appropriate. I think he thinks this is the best he can do. And the question is, well, is it better to do this, or is it better to invest it all in one arm?
Okay. What piece are you doing then, in terms of your role?
So I'm going to be helping with the rollout of the intervention. And I guess I'll be, my role is really to be mentored by the group, to sort of learn about research. This is the first clinical research that I've been involved with.
Do you have a niche though? Like I was going to say, I would grab like a niche of it so that you're going to get a piece
Right, yeah.
out of the end that maybe is.
And ideally this is something that I can sort of, obviously I'm interested in obstetrics, that I could sort of, use and, in my own way.
But if you found something here, like say physicians empowerment or something that you think, well, that would.
What's your question?
That would be and you make sure that you're getting the right data around it.
Yeah.
And then we could definitely support you in making sure you analyze that and that could be reported. So you can take a little chunk. I think it's great that you get mentored by Andrew, and that's what he does. But if there was something that you thought, I could take this a little further, so we'd encourage you to do that, and then we'd be here to make sure that you will support it. Because even if it was something that Andrew would say, that's not really where I was going to go, I don't want to invest too much time, we could say, well, that's okay, we'll help Vanessa do that here.